Hi, in this video I'm going to be talking about traumatic brain injuries and the various more advanced interventions that can be done in order to try and prevent serious consequences from these injuries. So I'm going to start by talking about coup and contra-coup injuries. So a coup injury is where you have a cerebral contusion, which is essentially bleeding, at the site where the brain has been impacted by the injury. A contra-coup injury, on the other hand, is where once you've had this impact on the head, the brain moves within the skull and collides with the opposite side of the skull, meaning that you have an injury on the opposite side from which the impact has occurred. So a cerebral contusion is where you have multiple microhemorrhages and leaking of the small vessels into the brain tissue. So this is essentially a bruise on the brain, and it's the same as a bruise in any other area where you have these small vessels bleeding. So this can cause focal neurological symptoms. So the symptoms that you see after a cerebral contusion will depend on the area that's affected, and this can be greater understood by understanding the anatomy of the cerebral cortex. This leaking from the small vessels can cause some swelling and a raise in the intracranial pressure, which is one of the key things to note in brain injury. So next we have concussion. Now, the mechanism by which concussion occurs is widely disputed. So in this video I'm going to explain one of the ideas for how it occurs, but this is not definitive. So concussion is often thought of as a mild traumatic brain injury, and it's where you have a head injury with a small temporary loss of brain function. So when you have this injury, you have a disruption of the membranes surrounding your nerve cells, which causes a shift in the potassium into the cell. This means that in order to try and move potassium out of the cell, there's an increase in the activity of the sodium-potassium pump, which is an active transporter. This means that the glucose gets used up, and so the glucose is consumed by these cells, so they don't have their usual reserve, meaning that they're in a low metabolic state. And this can cause the more long-term, and this is up to 4 weeks, effects of concussion, where people appear to be sort of processing information more slowly. Further to this, when there's an injury, there's accumulation of calcium within the cells, which can cause further impaired metabolism and may even cause some cell death. So in a clinical situation, a diagnosis of concussion is occurred when there's a short or no loss of consciousness, when there's memory loss of less than 24 hours, and where there's only a small reduction or no reduction in the GCS. And then there are focal neurological signs. So these essentially mean that there's no signs of a severe head injury. A diffuse axonal injury is a much more severe type of traumatic brain injury and has very poor prognosis. It causes extensive lesions to appear in the white matter of the brain, and this is because there's a difference in the density between the white matter of the brain and the grey matter of the brain, which means that when there's a head injury, there will be acceleration of the brain tissue, and then when the impact stops, there'll be a sudden deceleration of the brain injury, which means that they'll move at different rates. And this will lead to the shearing of the axons of the shared nerves between the white and grey matter. This means that the area distal to the point of the shearing will begin to degrade, and there'll be a series of biochemical cascades, and this is known as Wallerian degeneration. So the diagnosis is typically made through imaging, and you'll notice that there are small bleeds in the corpus callosum and cerebral cortex. And it's more obvious on an MRI in a more long-term time frame, but it can sometimes, in severe cases, be noted early on in CT scans. So This diagram shows on the left a normal axon, and then in the middle it shows the twisting and shearing of the axon during a traumatic injury. And then it shows that both the proximal and distal parts of the axon will begin to die away, and the more proximal parts in the white matter will start to form these white matter lesions. So one of the key problems that happens following most traumatic brain injuries is edema and swelling of the brain. So this is often known as vasogenic cerebral edema, and this is because it's caused by the vessels. So there's a breakdown of the blood-brain barrier, that's the BBB, when you have this traumatic brain injury. And this means that the proteins that are normally within the blood will pass into the extracellular space, which is what normally prevented by this blood-brain barrier. So we then have the movement of fluid from the vascular system and from the brain tissue into this extracellular space, meaning that you get this buildup of fluid around the brain, and this is swelling and is known as edema. So damage to the blood-brain barrier can be caused by trauma, and that's essentially just from the impact of the injury, or from malignant hypertension. So this is if there's a very, very high blood pressure present within the system. So if you have compression of the veins that are leaving the head, then this will cause more blood to be present and a higher pressure blood to be present in the capillaries surrounding the brain. And this will cause this malignant hypertension. So an example of this is in a self-hanging. Typically, this will cause compression of the veins in the neck, and this will then cause this high pressure and breakdown of the blood-brain barrier, and so you'll have this swelling and edema present around the brain. And this is, in most cases, how suicide hangings will lead to death. So there are then a number of different types of bleeds that can occur. So first we have an extra or epidural bleed, and this means that it sits outside the dural layers, which is the meninges. So this commonly occurs when you have bleeding from the middle meningeal artery, which runs just behind the pterion, which is around the area commonly known as your temple. So if you have an impact here, then this can commonly rupture this artery, and so you'll have bleeding into this area. And it will look like a biconvex disc, or a lentil, and it's also sometimes known as a lentiform shaped disc, when you view it on a CT scan. A subdural bleed, on the other hand, sits in the subdural space, which is underneath this dura mater. So there are veins that run from the brain tissue to the extradural space, because this is where you have your venous sinuses, and you've got veins bridging between these. And when you have rupture of these veins, they'll bleed into your subdural space. So this is very common in the elderly and the young, and this is because they have smaller brains compared to their skulls, so they've got these longer bridging veins. And this is often crescent-shaped when viewed on a CT scan. Then we have subarachnoid hemorrhage. So this is where you have bleeding in the subarachnoid space, which is underneath your arachnoid mater, which is another one of your meninges. So severe traumatic head injuries will cause rupturing of your arteries, and these can often be the arteries in your circle of Willis, for example, and this will cause significant bleeding into this space. And this will show blood present in the sulci and the ventricles and cisterns around the brain, and this is how you identify this on CT scans. So a number of the things that we've mentioned will lead to raised intracranial pressure, and this can be by a bleed, like is shown in this diagram, or it may be from the cerebral edema and swelling. And this can cause something called coning and herniation. So there are a number of different types of herniation, and this diagram shows them. So on this side of the brain here, we've got a bleed present, and this is causing the brain to be pushed across to the other side. So we have firstly a subfalcine herniation, and this is because we have this piece of tissue running down between the two lobes of the brain called the falx cerebri, and therefore when part of the brain from the other side gets pushed underneath this, it's known as subfalcine herniation. Then when the brain tissue starts to be pushed downwards, it's known as a transtentorial or central herniation. And if brain tissue starts to be pushed out of a break in the skull, then this is known as a transcalvarial herniation, and this is because the skull is sometimes known as the calvarium. The medial part of the temporal lobe is often known as the uncus of the temporal lobe. So if this starts to get pushed and it can herniate through and get pushed down like this, it's known as an uncal herniation. And then you have your tonsillar herniation, which is where the tonsils, which are at the bottom of the cerebellum, begin to be pushed down through the foramen magnum, where the brainstem and spinal cord sit. Then this is called tonsillar herniation. So obviously this compression and herniation of the brain is incredibly unhealthy, and so it's something that you want to try and fix as quickly as possible by preventing further swelling and decreasing the intracranial pressure. So something called an ICP bolt, which is essentially a screw which can be placed into the subdural space, can be used to immediately measure the intracranial pressure. And that means that if it's too high, you can rapidly try and perform interventions. More effective than this is an intraventricular drain, or an IVD. And this is like a catheter which is placed into the lateral ventricles. And this both provides a constant measurement of the intracranial pressure, and it can be used to drain away CSF, which means you've got less fluid present within the skull, which is your closed box, meaning that it can help to reduce swelling. And as mentioned previously, hypertonic saline and mannitol are two interventions that can be used to try and help control the intracranial pressure by reducing the amount of fluid around the brain. There are also some surgical options for decompression and preventing this raised ICP. So one is known as burr holes. So this can be used for your extraaxial bleeds, and these are your extra or subdural. And this is where you identify on imaging the site of a bleed or hematoma, and then you drill a hole directly through the skull, and then you may have to cut through the dura if it's subdural at the site of the hematoma, and then you evacuate the clot that has formed there. And this can actually be performed by non-experts, and this is something that a lot of people are trying to teach a wide number of general surgeons and other non-neurosurgical experts to be able to perform in an acute setting. And then a craniectomy is where you have a portion of the skull which is removed, and this allows the brain tissue to swell out into this space, so it's not being compressed. So it's sort of like a voluntary transcalvarial herniation out through sometimes a very large portion of the skull that's been removed, like in this diagram here. And this is provided by neurosurgeons and is more definitive treatment. So the last thing that we're going to talk about is the difference between somebody who's been drinking too much and somebody who's got a head injury and is starting to look like they maybe had some substance abuse. So one of the key things to remember is that when you have to have a certain level of blood alcohol in order to have mental confusion. And the amount of alcohol in your blood falls quite quickly, which means that if you have a patient who has a coma for more than a few hours, then it's very unlikely to be caused by the alcohol. So you want to start trying to make sure that you can exclude any other causes. And then there are a few other key symptoms of what are known as agitated head injuries, which are the head injuries where people start to look like maybe they're drunk, which you have to try and look out for, which are subtly different from how somebody with a small head injury who has drunk too much will show. So they will, of course, be confused, and this is often different from people who are just drunk, who, rather than being confused, are far more likely to be sort of aware of what's happening and be telling you no, they don't want your help, rather than just sort of pushing you away without saying anything. Then you've got abnormal movements. So somebody who's drunk a lot of alcohol will typically be in control of their movements to enough extent such that if you put a face mask on them to deliver some oxygen, if they don't want it there, they'll pick it off their face and throw it away. Whereas in an agitated head injury, the movements are often far more abnormal, and the person may be using, for example, the back of their hand to push away their face mask. The patient then may start to become aggressive, and again, this is something that can be present in alcohol, but often alcohol patients will be far more understanding, and rather than getting aggressive, they will maybe start to raise their voice, but generally are less physically aggressive. And there may be a change in personalities. So witnesses who are present might be saying, oh, they never normally behave like this. I don't know why they're behaving like this. They're normally very kind. They're normally very placid. So these are some of the key things that you can understand that you've got a patient with a severe head injury rather than a patient who has a small head injury and has also drunk too much alcohol, because that's obviously not something that you want to miss. So thank you very much for listening.